Good morning and welcome to the Substance Abuse Diagnosis and Treatment webinar brought to you by the Sri Lanka Association of New York, also known as SLANI, in collaboration with the Sri Lanka Medical Association of North America, Inc., also known as SLMANA. My name is Shamistra Nataraja, and I will be the moderators for this session. I would first like to thank Dr. Trikanti Rajapaksa, President of SLMANA, for all the help in getting the physicians together for this webinar and all the support that she has provided for us behind the scenes. I also want to thank the SLANI committee for all their support in helping to make this webinar a success. I want to especially thank Sanjeev Silva, the past president of SLANI, without whose support this webinar would not have taken place in such a seamless fashion. Sanjeev, I cannot thank you enough. As you all know, the COVID situation in Sri Lanka is really dismal. It is a disaster. SLMANA has started an email/letter writing campaign to President Biden and Vice President Kamala Harris, requesting them to send vaccines to Sri Lanka, which they are in dire need of. The more signatures that we have, the stronger will be that request. We will send the link to that letter via email to all the registrants on this webinar. Please share this link with all your network, basically anyone who would like to support Sri Lanka. And the more signatures that we have, the stronger will be our request. Now that we have got that all out of the way, let's get to our webinar. We will start off with our main presentation, which will be followed by a question and answer question and answer period for our panelists. During registration, you all had the option to submit questions. And while we are going through this presentation, you also can post additional questions through the Zoom panel. So today we are very fortunate to have as our main speaker, Dr. Gregory Sathananthan, who is a long-standing SLMANA member, as well as being one of the founding members of SLANI. In addition, our panelists consist of Dr. Takshan de Alwis, also both a long-standing member of SLMANA as well as SLANI, Dr. Laura Ancona, and Dr. Raghunath Mehta will also provide great insights into this disease. Without further ado, let me introduce Dr. Sathananthan. Gregory, take it away.
Hi, my name is Gregory Sathananthan, and welcome to the program. To adjust some issues, I'm going to talk in addition to substance abuse about alcohol abuse too. Two words I'm going to use. I'll use the word sparingly. I'd call that person afflicted with the disease. And also those who are affected, those who are burdened because of the disease is another person. I'll call them, for a better term, called caregivers. First, let us look at the extent of this disease. Next slide. Yeah, this is the federal government figures of the extent of the disease. Alcohol has about 15 million people affected by the disease. And this is a fairly accurate account because they can trace it back from the store sales and the bar sales. So if you convert this, that is about 1 in 10 people in the United States and most probably worldwide have this problem, the alcohol use problem. The others are very underestimated because those mostly are illegal drugs. So no one is coming forward to say that I am an opiate or I'm a cocaine user. So there are much more users in this lower category than what is reflected here. Just for example, the year ending March 2020 reported 80,000 opiate overdose deaths. But here we find only 2.5 million claimed as users So the figures do not jive. That doesn't mean that every third person who uses dies. It's not right. The next slide, please. American Psychiatric Association about 15 to 20 years ago defined alcohol and substance abuse as a disease, a chronic disease, just like diabetes, hypertension, cancer, and or heart disease. What does a chronic disease mean? A chronic disease, if untreated, is progressive and will end in hospitalization or death. For substance abuse and alcohol, there's another endpoint. It is jail. When you talk about a disease, there's no one single point for the disease. It is a spectrum. It can be either mild, moderate, or severe. Most of the media, journalists, and other people portray alcohol and drug abuse users in the right-hand spectrum, which is severe. They talk about the public drunk shooting drugs in the park or in public or in homeless shelters. So that is not where I'm going to talk about. These are the severe cases who are not going for treatment, and their prognosis is poor. I'm going to emphasize mostly on the mild and the moderate cases which can be treated, and the outcomes are good if there is early treatment. The next slide, please. I have categorized this mental and alcohol abuse into three phases. One is the mental aspect of the disease, the physical aspect of the disease, and the spiritual aspect of the disease. Mental aspect, you have the fears, anger, aggression, your anxieties, and later on it can go to paranoid ideations and delusions as it becomes severe. Physical, small things like cough, colds, bronchitis, abdominal symptoms, diarrhea, muscle wasting, weakness, and then they can go on to other severe diseases like HIV, hepatitis C, or cirrhosis. Spiritual, I'm not talking any of religious things. I'm talking of more moral values. With this disease, there's a degradation of the moral values, which I say leads to stealing, lying, and cheating. How can we spot this early signs? I said we don't want to go to the severe signs because the treatment is much more difficult and the patient is not willing to get into treatment. We are trying to see how we can catch these things earlier. This is a busy slide, but I'll break it down. Focus on the left side, the changes in the personality. As they start using drugs and alcohol, they lack interest in things that were previously important. For a student, it might be sports, school. For an adult, work, social obligations, missing anniversaries, that type of thing. Neglecting relationships, you neglect relationships with your parents, spouses, siblings, and others. Missing important obligations. Every user has gone through this. Missing a game of a child, or a child not remembering the parents' birthdays, and there are others. Otherwise, there are other obligations that they might forget, like going to the grocery store and not bringing the stuff, ignoring negative consequences. And it happens to an addict that they might have a small negative consequence, like getting caught stealing. And they say, this is nothing much, it was a small amount, I'm not going to do this again. But if it continues to drug and use alcohol, these consequences become more severe. And as the person uses more and more, he or she doesn't want other people to know about the use, so they isolate themselves. For the students, there's an academic decline. The mood swings. A person who has a steady mood suddenly becomes high or suddenly becomes low. Anger and aggression is common. Irritability is common after use. There is depression, apathy can lead to suicidal thoughts or lack of social pleasure, especially with academic decline. Why I have put the arrows here? These personality changes and the mental changes do not appear in a vacuum. They interact with each other. So like neglecting relationship can lead to anger between the two parties, can lead to irritability, lead to mood swings. Ignoring negative consequences can, after some time, can lead to depression, apathy, and suicidal thoughts. For the listeners, what I want to for you all to do, instead of just memorizing this, look at this and see whether you can identify with these things, whether you have a mood swing, whether you have neglected relationship, missed obligations, depression, lack of social pressure. If the user has 2 or 3 things, it's strongly felt that he or she might have a problem. And look at yourself and see, if you have not looked at yourself, again, see whether you have a problem or not. If you think you have a problem, you have a problem. Or for the caretakers, again, look at this and see any of your loved ones are having any of these symptoms. And if 2 or 3 of they have 2 or 3 of these symptoms, it's a red flag. Not necessarily they have substance abuse, but it has to be ruled out. Next slide, please. As I said, it's a physical, mental health, affects physical and mental health. So there's physically, there's constant illness. The drug and the alcohol impair the immune system. So these people are liable for small diseases like colds, coughs, bronchitis, pneumonia, abdominal problems, leg weakness, joint pain. So those are small ones, and then lead to various consequences. Can go to pneumonia or cirrhosis and other things. And the constant illnesses can lead to consequences. You have always heard about a Monday morning call in sickness, because they're because of the illness they are not ready to work on Monday. Changes in weight, it can usually is a loss of weight. Because of the drug use, they neglect their food intake and forget or don't have an appetite, they lose weight. Or on the other hand, they might live on junk food and increase weight. That's not a common thing, but decrease in weight is common. Increased tolerance, this is for the person who is using it. As you use, you get a tolerance, and therefore you increase the quantity of the use and the frequency of the use. So if you feel that recently you have to get a higher dose or more drinks and drink or drug frequently, again, that is a sign that you are going downhill. Sleep disorders, if with the active drug, you are like cocaine, you can be up for about 2 days and come crashing down. Or with alcohol or opiates, there's depressives, and you can sleep more than others. Next slide, please. Co-occurring diseases. Any disease doesn't appear in a vacuum. Say, take for diabetes. Diabetes can have high blood pressure. High blood pressure. You can have hypercholesteremia. You can have heart disease. You can even have rheumatoid disorders. So unless you treat these diseases concurrently with the diabetic treatment, the diabetic treatment is not optimum. It's not optimum. The treatment is, the outcome is impaired. So with substance abuse disorders. The common disorders that enhance substance abuse disorders are number 1, depression, which can have an independent origin or caused by substance abuse. Usually people treat their depression, self-medicate themselves, alcohol and drugs. And initially there's a slight success, But as time goes on, there's a tolerance, and the quantity and the frequency increases, and you end up with a double problem of depression and substance use. ADHD is a adult the attention deficit hyperactive syndrome disease has a much higher incidence of alcohol and substance abuse than normal. Post-traumatic stress disorder is the same thing. Whenever you evaluate PTSD, always ask the alcohol and drug abuse history. Bipolar disorder, a common disorder in the mental health field, carries a occurring incidence of almost 50 to 60% of alcohol and drug abuse. Physical and sexual abuse is important. This is suppressed in most instances in our society. Data indicates they have a higher incidence. Usually with sexual and physical abuse, there is also PTSD involved. So this can be combined, and that cause a heavy use of substance abuse and alcohol. Low self-esteem, like depression, you're trying to self-medicate yourself and end up with two problems. Heavy genetic component is a family history. If you have a family history, be careful of the next generation. It is not a dominant gene, it's a secondary gene. That might be transmitted. There are also recent data, it might skip a generation, which means the grandparents have a history of alcohol and drug abuse. The next generation won't have it, but the grandchildren might have it, and be careful and be observant. Next slide, please. Now we have done what the disease is. We have early signs, and we have seen how we can spot the early signs. Is there a treatment? Treatment is very confusing. People say, I have this person has a problem. He or she to go for treatment. Even my medical community is a bit confused about what treatment they should get. I'll here say there are two things that you have to treat in this disease. The two components. One is a compulsion, which is a physical component of the disease, and obsession, which is a mental component of the disease. By compulsion, I mean that the need to drink, as soon as the drug level goes or alcohol level goes down on a person, he or she wants another drink. And it's a common parlance in the drug circles. It says a man takes a drink. The next step is the drink takes the drink, or the substance takes a substance. So you have now a compulsion that you have to continue to use these drugs, and you're afraid to stop it because of the withdrawal effects. Obsession is the people the drug user for years and years has been obsessed with the drug, and that is his or her primary purpose in his life. Obsessed with these drugs, how to get it, where to get it, where should I stack it, how do I get the money to do it, and these are the thoughts that go on, and that's a mental process of the disease. There are obsessions with food, fitness, death in older people, but the classical obsession is two lovers being obsessed with each other. And we can use this model for substance abuse and the substance. For years, the substance user and the substance have been carrying on illicit love relationship between them and obsessed with each other. Next slide, please. How do you manage compulsion? It's a physical thing, and so it's pretty easy. If you stop using the drug or alcohol for about 4 or 7 days, the compulsion goes away. The body does not need the drug. Body can function without the drug or alcohol. And these are called detoxes, which are usually 5 to 7 days. I don't advocate you to detox on your own, because there are a lot of withdrawal effects, which some are dangerous, some are very uncomfortable. So in all these detoxes, people will take care of your withdrawal effects and also help you with the withdrawal effects with some medication. Only with, except in alcohol and barbiturates, I would highly recommend, we recommend that you use a medically supervised detox. Because of the withdrawal effects, alcohol can cause delirium tremens, and barbiturate alcohol causes seizures. Next slide, please. Okay, we have, by compulsion, we have disrupted this love affair between the user and the drug. So what happens when two lovers are forcibly separated? One lover, the drug user, is yearning for the drug, wants to come near the drug. He or she is angry and has guilt feelings and always attracted towards the drug. And this is the mental status that we have to treat in treatment of obsession. This can, the obsession can last for 6 months, 9 months. It is very individualistic. Sometimes it goes off in 2 months. So I won't predict a period of time. We have seen obsessions lasting up to an hour. The first baby step is a rehabilitation program, which is 3 to 4 weeks. In rare cases, can be 3 months. In this rehab program, the person will learn the nature of the disease, how it affects the people, and the benefits of sobriety. Also, from the senior people in the rehab who have finished two weeks or 3 weeks, the newcomer will learn how they have benefited from this program and what are the virtues of staying sober, and learn from them what they are going to do after they leave the rehab. So the rehab is, a lot of people think rehab is the end of treatment. No, because it's only a baby step. This is a chronic illness, so you have to treat it. To arrest this disease, you have some treatments going on. Otherwise, the disease will come back and it is called a relapse. There are self-help groups which can Alcoholics Anonymous and Narcotics Anonymous, but there are other groups that don't contribute to the AA or any philosophy and treat people independently. In the southern states, where the Southern Baptist Church is strong, they have their own self-help groups that don't contribute to AA or NA, and they have been successful. Counseling and therapy, as you know the nature of the disease, what has happened to you and what can happen to you in the future. But one of the most important things is during counseling and therapy, will uncover your co-occurring diseases and can be treated, can be referred for treatment to appropriate authorities. And if that is done, the outcome of treatment of the substance abuse is pretty much enhanced. Mandated treatment, I'll do this in detail later. You can go to the school counselor, get the help, go to work, the EPA, the Employment Assistance Program, go to the supervisor at work, and various ways you can mandate treatment. There are medications available, but this has to be discussed with the doctor, and the plan is very individualized, so I don't want to go into that again. Next slide, please. The opiates, they're just a thing to say there are drugs available. These are some of the drugs. So we have done the early science, principles of treatment, and the principles of treatment. And what do you do after that? After that, and it's not after that, together with this disease, we ignore one part of the people who are involved in this process. And they are the caregivers. Next slide, please. The caregivers are people who are burdened by the other person's disease and develop symptoms. As I said, there are, for every addict, there are 3 to 4 caregivers who are affected by the disease. They are about, which means about a quarter of the population are affected by the disease. What they get themselves into, guilt, blaming themselves for what happened. A parent might think, what did I do to my child? What didn't do? Was I too harsh, or was not harsh enough? Two couples who married the ideal each other find someone drinking or drugging, and then will always be obsessed and say, what did I do, or what did not I do. So you blame yourself. There's shame because you don't want society to know that what is happening in your house. So you withdraw from society. You have anger at the person who is using it, and anger at yourself because you think you caused it. Uniqueness, again, you think you are the only person in the world who is suffering from this, not knowing that about quarter uh, uh, part of the population in the world is suffering from this. Loneliness, as you have guilt, shame, and uniqueness, you withdraw from society and become a lonely person. And a constant sense of failure will also cause depression, and a combination of loneliness and depression can lead to suicidal thoughts. So be careful. Can we do anything about it? Yes, sure. Next. Yeah, we have self-help groups, AS, Al-Anon, and Narcon, but self-help groups are not unique to the substance abuse. There are self-help groups of cancer, PTSD, suicidal loss survivors, bereavement. So this is part of a worldwide self-help groups, part of which is alcohol and drug abuse. What happens is self-help groups is that you go to the people who have similar problems, and you learn that you're not unique, you're not that guilty, there's no shame, you don't have to shame yourself. So you are relieved with this, and the other parties or senior will be able to help you how they overcame these diseases. So I strongly advise you to seek some self-help groups. Group and individual therapy is the same thing that what we did with the abuser. You unravel some of your problems, and also if any coexisting diseases can be treated, especially depression, or if you have neglected your physical health. Always protect your physical and mental health. We are done with mental health. Physical health, because you're focused on the addict, you don't take care of yourself. You don't eat, your sleep is impaired. Sometimes you even cancel doctor's appointments, and your physical health goes downhill. So be careful and protect your physical health. Tough love, this is the two words used in the recovering community. It's like what he's saying is that you draw a line where the addict will not cross. So if he or she crosses that line, then there are consequences. Hopefully, but still you say that you love them and respect them. But initially, if it might work, if it doesn't work, because the addict will usually cross the line numerous times, and your love for the person might lessen and lessen, and sometimes this intervention might not work. Establish a local network. Like any other community, the Sri Lankan community uh, does not like to seek outside help. So what I would suggest is to establish small groups with the caregivers, maybe one or two or three, uh, just to help you. The self-help groups, AA, was founded by two people, and it grew into a worldwide organization. It's just two people at the start. And if you can establish a small network, you can telephone each other, you can go for breakfast, you can go for lunch, and here you can discuss what you are facing and things that will help you, just like the self-help group. You won't feel that unique, that shame will disappear, the guilt might lessen, and also other people might say how they solve some of their problems. And then you can also tell them how you solve some of their problems. So it is a great opportunity for you to receive things and also to give things, which is really a part of happiness in life, to give and receive. Also, in Sri Lanka, so in New York, I recommend that you get involved as an ongoing project. If some of your volunteers can know some caregivers and just hook up two or three together and see how it grows. Might work out, might not work out, but it's a thing worth following. So if you can establish 2 or 3 networks like that and see what the outcome would be. Next slide, please. This is putting, when you treat or someone is in treatment, how do you know that person is improving? A lot of people think that you, when you go for treatment, immediate improvement occurs. It's not so. First, we have what is called the pre-contemplation stage, or what is called the denial. The person has the problem and says, no, I don't have a problem. The student might say, I'm going to school, I'm participating in activities, games, I don't have a problem. The spouse might say, I have a job, I bring a check, I have a car, I have a house, I have kids, I don't have a problem. But the caregivers and the world around him or her see that his world is disintegrating as it goes on. Can you do anything in this pre-contemplation stage? I see one of the things that I mentioned earlier, you can go to the school counselor and ask him or her to mandate treatment. EPA, which is an employment assistance program in all workplaces. It's a confidential thing. You can go and ask for treatment. You can always go to work. But there is another treatment which is called the intervention treatment, where your family and the extended family meets the user and confronts him or her with the damage he or she is using and how they are getting damaged. This has to be under the supervisor of an intervention specialist who can guide this. And this has successful treatments have happened, taking them all into treatment immediately, but that is not normal. But a fair amount of people have improved with this. So don't do it without help, because you'll get end up with fist fights. The pre-contemplation stage, next movement is a contemplation stage. Here are what the caregivers are going to observe, is there recovery there. Contemplation stage is he or she will say, yes, I have a problem, but I can handle this. I can sell my willpower, or I can read some self-help books and get help. In these two things, we can use the same interventions I told about pre-contemplation. In the preparation and stage, you say, yes, I have a problem, I need help, but continues to procrastinate. And here the caregivers can help by taking them to self-help groups, to family therapy, or discussing with them, how can we move you from here to here. Action stage is where the person takes action, goes to a treatment, rehab, or a self-help group. And then you have to maintain your treatment after the action group. Again, if you don't maintain, it's a chronic disease, so it'll progress. Relapse is common in this disease, and don't be downhearted. Relapse is a part of this disease, and you can always come back. With each relapse, you are a better person. You have at least at the willpower to accept this, and you have learned a lot from treatment, so you can always keep on applying this for your next time. You don't have to go to the pre-contemplation stage. Usually it's at the relapse takes at the action stage, and you can go back to the action stage and the maintenance stage. The users, I'll tell you, the best indication for good outcome of substance abuse treatment is continuation of treatment. So try to remain in this cycle. And for the caregivers, be part of the recovery. As I said, go to meetings with them, go to therapy once in a way, and talk to them and see that how they're functioning and how you can help them. And also don't cut off relationship with them. Once you cut off, it's very difficult to get back. Usually Sri Lankans say, don't talk to me, don't come to my house. And the final thing is, don't even come to my funeral. And these are harsh words. So if the addict recovers, there's a huge problem of to get the relationship back and going. My last slide is where the resources are. You can get it. This will be in the SLMANA Sri Lanka Association website. You can get some sites a good website. It has got of resources, addiction center, narcotics animals, Alcoholics Anonymous, and NIDA. NIDA's website is drugabuse.gov. So that is the end of my talk. Thank you very much for listening to me. And thank you, the president, Mrs. Nadraja of the association, for inviting me to join this program.
Thank you very much, Gregory. That was wonderful and so informative. Thank you so much. And with that, we are now going to be opening up to the entire panel. We have several questions that we have already received. And I'm going to start opening questions for the panel. And the way we are going to use, we're going to structure this is that any of the panelists can answer, and it's not limited to one panelist. So I know every panelist will have different perspectives on the same question. So feel free to please jump in and start from there. Okay. So the first question that I have for the panel is the legal use of marijuana is spreading in the United States. I believe right now there are about 17 states where it's legal. So does that mean that marijuana isn't addictive? Who wants to take that?
So it's a very comprehensive question, and it's probably going to be talked about more amongst psychiatrists and general physicians as life goes on. So marijuana used to be a substance that people use recreationally. We all know that we use it for chronic pain and for certain seizure disorders in pediatric communities. But it is now thought to be addictive because there are centers in your brain that receive cannabinoids, and it can make the brain very vulnerable. So studies have shown that when adolescents and college students are using daily in whatever form, in edibles or smoking, that it can produce a chronicity, which over time can develop problems, meaning, you know, in the young brain, remember, if high school students are using, they're not really developed completely. So it can become an emotional and a very euphoric feeling. So remember, it's not just the complicated receptors in your brain that are using the addiction process. It's also the memory of how wonderful it feels to be high. So that feeling becomes addictive. And then later on, we know that some patients who have a predisposition for psychosis can produce psychotic episodes when they're smoking cannabis. So there are risks.
Thank you.
I think I would like to add on to what Dr. Ancona said. She covered it very nicely. One of the things that I experienced while practicing addiction psychiatry is a close association between substance use disorders and criminal behavior. And I'll be very brief here. I think it is very well known that the people who use drugs, they suffer from extraordinary amount of craving. Dr. Sathananthan called it compulsion. I would call it craving. And the craving is so strong that they would do anything to get the drug to address their withdrawal symptoms, including stealing, robbing. So coming back to marijuana, I think the legalization of marijuana has a number of factors that we need to consider. One is that there was a time, at least in New York metropolitan area, where people were being hauled to jails and to prisons, even with a small amount of marijuana on their person. And it did not do any good. It did not cure their marijuana use disorder. So one of the things that the states have done is by legalizing marijuana, they are reducing the criminal behavior, and they are reducing people being incarcerated, you know, into their jails and prisons. That's number one. Number two, basically, at this point in time, there is a general agreement that a a use of marijuana in of itself would not lead to the serious consequences unless somebody is a very heavy user. And as Dr. Ancona said, somebody is already predisposed to having psychotic symptoms. So there is a segment of population where it can cause problems. But other than that, there seems to be general agreement that if people use marijuana, unless the use is very heavy, it is unlikely to cause any serious damage bodily or mentally, as alcohol does or as tobacco does. There's one more thing, and then I will shut up. Chronic use of marijuana has been known to cause what is generally regarded in psychiatric community as a motivational syndrome. A motivational syndrome is basically loss of motives. People become kind of goalless, motiveless, they feel depressed, they feel lethargic, they don't want to do anything, they stay in bed, they don't go to school or college or to their work. And it almost looks like a semi-depression that can last for quite a while. So that is one of the long-term effects of chronic marijuana use.
Yeah.
Thank you.
If I may add,
Sure, Dr. Hartiel.
yeah, if I may add what's already been said, the question was, does it, just because it's legal, does it mean it's not addictive? And the classic example, of course, is alcohol. Alcohol has been legal for years, but it's highly addictive. And so just because something is legal does not necessarily mean that it's not addictive. And I've also known, just like alcohol, increased availability increases consumption in the population. So we are going to see a whole explosion in the use of marijuana. Second point I wanted to make was that, marijuana has two main components, the THC, the tetrahydrocannabinol, that is the addictive component. And as part of it is the CBD, the cannabidiol. They say that is not addictive, but it has like a calming influence. And that has more medicinal properties. And most of the people who vape marijuana using these aerosolizers like electronic cigarettes, they use this CBD oil and CBD-laced plant material and use that stuff. So I don't want to say that that I'm fully in agreement with the fact that light users probably are getting away with it, but heavy users of real marijuana containing THC is probably a big hazard for people. That people see it as a gateway drug. I don't know whether Dr. Mehta agrees, but that people who use marijuana and get a high from it will be chasing a higher high with hard drugs. So some people dispute this theory, but I think there may be some validity. Thank you.
No, I agree with Dr. Alwis that those who are predisposed to addiction, they are looking for higher highs and higher highs and higher highs. So I do believe it's a gateway drug. Yes. And also, I did not mention there has been some literature that indicates that a chronic heavy use of marijuana can lead to DNA damage and the chromosomal damage. There have been a number of papers in the past. It's kind of disputed at this point in time, so I will not go more into it at this time.
So there is a follow-up question. I think you kind of touched on it, but I think y'all were talking more about heavy use. But the question is, what is the impact of recreational marijuana use on the adolescent brain and behavior? So I know we all touched, I think Dr. Ancona touched on the adolescent brain, but I think she was talking about more chronic, more, I guess, heavy use versus just recreational marijuana use, right? Just smoking it at a party or so on. Is there an impact? Is there an effect on the adolescent brain with a recreational use? Dr. Ancona, you want to talk about that?
I think the two words are going to be confusing. So, and the bigger component is to determine the actual amount of use. Because when we say the word recreational, we tend to think that it is harmless. So even the word recreational has to be quantified. So it's better to quantify how many times, I have patients who, if I don't ask, if, you know, they're having trouble sleeping, but then in the third or fourth visit, they'll tell me, well, every night I smoke a joint, I get relaxed and I go to sleep. That's very specific. So like anything else in psychiatry, just like you take a history for smoking, for inpatient hospitalizations, or people's mood, you have to quantify this and then qualify it. Because recreational is what we all think it is. It's harmless. But this question is teetering between, if I smoke twice a week, is that really bad? Well, I don't know. You have to also remember that cannabis these days is a very dirty drug. We can't control it. And you, on the market now, we're going to be exposed with what consumers are confronted with, just like what was mentioned with alcohol. Because we can be a white wine drinker twice a week, or we could have a steady 2-bottle vodka addiction. So the issue here is to quantify it, and then we can qualify it. Because the word recreational, I know what's coming now is that people think that it's going to be the recreational use and it's legal. Doesn't make it less harmful.
Thank you. Yeah, I think as parents, grandparents, I think the concern is now that our,
Yes.
children are going to start smoking this, and is this going to have a long-term impact on their brains and, so on. I think that's the concern.
And remember, the United States went through prohibition.
Mhm.
The government, society, capitalists, the bootleggers, if we look to prohibition, that was a time when the concept of drinking was really different than it is now. So we're living in very historical times. So the production, the capitalism, the political factors around all of this are going to affect the consumer. So it'll be very interesting.
Yeah, and one of the things, recreational use, but some people have a proclivity, a proneness to addictive,
Yes.
you call it addictive personality, like a sensation-seeking personality. People who like to drive racing cars and do skydiving and stuff like that. So your brain is wired like that, and the adolescent brain is still developing, especially between 14 and 16. And during that time, if you're exposing yourself to these drugs, I'm not sure we know even how it'll impact the development of those kinds of circuits. And those memories can get imprinted in another part of the brain and lead to further drug-seeking behavior, perhaps throughout your life. But it will happen only to some people. This is the problem. And we can't identify who it will happen to. So my advice is, don't start anything. You may not be able to stop.
I would agree with Dr. Alwis 100%. That if you have a choice, don't even start it. I totally agree with you. But not to move the direction of the conversation in a different way, but we've got two drugs that are totally accepted by the society. One is called alcohol and other is called tobacco.
I think Dr. Mehta froze, right?
A bit, yeah.
Dr. Mehta, can you hear us? Okay, all right, let's keep going. Okay, I think that was great. And so this is another follow-up question. So even though you use it once in a while, can you get addicted to drugs, to a particular drug?
The literature says with any drug or alcohol or marijuana, majority of the people can use it and leave it. What we see as physicians and mental health people, we are looking at the extreme severe cases where people who have problems with the drugs. So we assume that marijuana causes it. Therefore, all marijuana users have to be on the alert. We don't alert this to alcohol. The person comes with an alcohol issue. We are not worried about the safe uses of alcohol. So if it is a human nature to dabble with these things occasionally, is this from a parent?
I believe, yes, it is.
So it's a question of if you have your own fears and other things that you have to address your own fears, and also the risk that people use it, and eventually 5-10 years from now anything can happen. But for the immediate thing, it has to be observed and see whether the person is increasing the use, the frequency of the use, and as I mentioned in my early signs slide, if there are any disruption in the relationships or there are any mental changes. And if those happen, then that's a red flag.
I will add to what Dr. Sathananthan said. Of all the drugs, the whole spectrum of drugs, alcohol, tobacco, amphetamines, cocaine, LSD, and, of all the drugs in my experience, there are two drugs which even with occasional use can get you into trouble. One would be the cocaine. And basically what the cocaine does is when people take cocaine, they're transported into another world. They feel ecstatic, they feel they have a lot of energy, they can solve all the problems, that they are facing, not a worry in the world. It produces what is akin to a temporary manic state. Okay, unfortunately, it doesn't last too long, and then they crash. And when they crash, they are back into the same old doldrums. So in order to get to that high, there is a strong tendency in cocaine users to use it over and over and over again. And pretty much the same thing can be said about heroin. When I worked in the addiction clinic, I was surprised how many heroin users were actually depressed, some quite clinically depressed, and some had what we call in psychiatry subsyndromal depression, basically that they were not depressed clinically, but underneath there was a lot of sadness and depression. And heroin use also, even though it may start occasionally, it may start from their father's medicine cabinet or grandfather's medicine cabinet. They start with the prescription drugs, taking OxyContin or Viacodin or Percocet or Percodan on an experimental basis. And before you know it, they like the feeling, they like the calmness, the tranquility, the euphoria it produces so much that they want to do it over and over and over again. So I would say of all the drugs, heroin and cocaine, even the occasional use in the beginning can land them into trouble later on.
Thank you. Dr. Ancona, did you have something to add to that?
Not to that, no.
Okay, thank you. Okay, so can drug addiction lead to other mental health disorders?
So I think it's a great question. I think it represents what parents or what families are often afraid of, is that can the use of a substance, even a light use of a substance, or the experimentation with substances, can that lead to something that produces, a real diagnosis or a mental illness? Mm-hmm. But I think we have to remember that, mood disorders, fluctuations in cognition are really affected by what motivates people to use a substance, because I don't think one can occur without the other. Sometimes people may be depressed and they may be using cocaine on a weekend to just feel better. So the point to the question is, I don't think you can separate them. The real fear is, can use of a serious substance really lead to a serious permanent disorder, something that we actually can call bipolar disorder or schizophrenia? Right. It can be a prodromal phase. It can cause you to understand that the brain is vulnerable, so something may develop. That's why it's important to look at the person who's having problems holistically, meaning that it's just, you can't separate the brain from the mind. So we have to be very careful about finding out what the person feels. So the answer is yes, possibly.
I would simply add to it. I think Dr. Sathananthan covered it very nicely in his presenting talk, that, the question that we have in front of us is, does the mental illness lead to substance use, or does the substance use lead to mental illness, okay? And often they run parallel course, because I think, as you mentioned, there are a host of conditions that you mentioned, like anxiety, chronic anxiety, depression, social anxiety disorder. People start using alcohol in order to allay their anxiety, to their depressive feelings, in order to sleep at night, you know. So this is how it starts. So the question, even though the question is framed, can the chronic addiction lead to mental disorders? I would rephrase it by saying that a chronic use of any substance would often lead to accentuation of anxiety, of depression, of sleeplessness. Almost every drug that we talk about here today has some withdrawal symptoms. And whereas it may not lead, you know, I'm not saying that alcohol would lead to schizophrenia or alcohol would lead to depression or to bipolar disorder. The fact of the matter is that in many people, the disease and the alcohol addiction, what we call, will run together, okay? If you want to be very literal about it, yes, alcohol and opioids both are central nervous system depressants. So chronic use of alcohol and chronic use of opioids can lead to depression, yes.
Thank you.
Another thing I want to say, in addition to what's been said, like alcohol can, severe use over the years can lead to impairment of your intellectual ability, basically lead to dementia. It's called alcoholic dementia. That's like an end stage. That's what Dr. Sathananthan was saying. We can't, we're not discussing that class, but that is the end stage of the disease. One other thing I want to say is about, we mentioned anxiety and depression, Dr. Ancona and Dr. Mehta, but you know, schizophrenia, a condition of psychosis, one of the most serious mental illnesses we have encountered in psychiatry is schizophrenia. And the original theory about the etiology of schizophrenia, that it was due to increase in dopamine in the brain, was a result of people abusing amphetamines. They found that people who abused amphetamines heavily had a mental condition presentation indistinguishable from schizophrenia. They were psychotic. Okay? So now, when they stopped using, most of them would, it got better, but others would persist. Now, we don't know whether they had a propensity to develop schizophrenia, and this kind of unmasked it. So again, you know, when I used to work at the VA, I had a couple of guys who would say, you know, all the families would say this guy was fine, and then he started abusing methamphetamine. Now they're saying he has psychosis and he has schizophrenia, and it becomes a self, I guess, it's self generating illness, ongoing illness. So again, my advice is don't try it.
Yeah, okay.
Yeah, I think I would, you know, without getting into biochemistry and neurotransmitters too much, one of the theories of addiction is that people who suffer from addiction have a dopamine deficiency. And almost all the drugs that we discussed today, alcohol, tobacco, you know, amphetamine, cocaine, they all basically increase the dopamine. And this is called the reward mechanism. Dr. Alwis mentioned about schizophrenia. Schizophrenics tend to have a very high rate of smoking. And I talked to them a lot of times. They say, well, smoking relaxes us, makes us calm. Basically, what the smoking does is it stimulates nicotinic receptors in the brain. It increases the dopamine. So does amphetamine and cocaine. So that's getting into, you know, what is the basic mechanism underneath many of these addictions, and what do these substances do to the brain? They increase the dopamine.
Okay, another question that has come through the panel is, what are some of the risk factors that cause addiction?
Some of the risks, sorry, go ahead, Dr. Ancona.
No, go ahead. Go ahead.
No, go ahead.
I mean, it's hard to say. I mean, that question comes from, again, a basic, you know, nervousness about watching and waiting to see whether or not a family member may develop such a problem. Risk factors can be many, but they can be emotional risk factors, there can be genetic risk factors, there can be dynamic risk factors. If we talk about adolescents, even college-age students have tremendous societal pressures, on them when they go from high school to college. So it may be experimentation. It may be the personality structure is experimental in nature. We talked about people who like to take risks. So, I mean, we can't speak about this when we talk about heart disease, when we all know the risk factors, high cholesterol, smoking, hypertension. But there are risk factors within families, especially if children grow up in a family where they're witnessing substance use, or they grow up thinking that substance use is tolerated and incorporated in the problems of the family. So I would say there are emotional risk factors, genetic risk factors, and when students or young adults find themselves in situations where they are not feeling very well, or they have a tendency to be anxious, or they want to make themselves feel better in times of depression, they may experiment and find out that some of the substances that they use will make them feel more socially and more emotionally intact. So I think it comes from a more emotional point of view.
Thank you, Dr. Ancona. Any of the other panelists?
Yeah, Dr. Kanab said family history is important because that's pretty established that if there is drug abuse or alcohol abuse in the family, there is a risk factor for the next generation to have it. And also, if you look at the personality of the child, one of the risk factors, if the child doesn't have peer interactions and isolated, that would be one of the risk factors, because sometime or another this child is going to have to replace that pleasure of peer interaction with something else. So if the person doesn't have any friends, isolating himself or herself, not taking part in sports for no valid reason, you have to talk to them. Don't talk about substances, but talk to them. Why are you not doing it? Why aren't your friends coming over? And the third one is peer pressure. In school, high school, obviously it's very rampant at marijuana and alcohol. So you are exposed to this, and once you are exposed, of course, there is a chance later on that you might develop it. And the famous thing is colleges. When you go, you join a society, and there's heavy drinking there, and Samishra, you know about this. So, so heavy drinking, and that might precipitate. So it's though it is a risk factor, it is again a parent's responsibility to monitor this child all along to see whether there's any significant personality changes. So you cannot predict it, but if there's a family history, you have to be careful.
Yeah.
So that brings me into a question that was just posted on the Q&A that's coming through right now through the chat. It's talking specifically about alcohol use. It's a pretty long, I'm going to try to summarize the question. It says that alcohol use is, pretty much accepted widely, in society. And so it says in young adults, it's not forbidden, but as parents, we teach the value of moderation with hard limits, like not drinking and driving, prioritizing on college, work, relationships, etc. This, of course, for the young adult, and they ask the parent, can I have a beer when I go to a party? What is the recommendation of the panel? As parents, they're asking, should we recommend total abstinence? Or as a parent, are we okay to say, have a beer or two at home or at a party? It's okay.
Well, I think that these are questions that will make me say to the family, you are the experts, not us, because that's a very common, very appropriate question. And it comes with the anxiety about letting children do all kinds of things, giving them a driver's license, letting them live in a different college town, and knowing what they may face. So I think that the families from day one are the experts on knowing their own children. So in your family, if your grandfather let you taste a little bit of wine at the table, that's something that the family is comfortable with. If you start to visit your college student in a college town and they're not the drinking age for the state, they cannot drink in a bar or on campus. So it's important to look at the rules and the laws, and it's important to have a talk with some of your children. And if you like beer, and if you're drinking beer with your son or daughter and you're having a beer, you might want to talk about how to introduce them to that. So they're not going to abstain, but you also have to look at your own values about how much wine you order with dinner or how many beers is a good idea, because it's a very, very frightening thing to watch your growing children drink a beer. Maybe. It has to do with your own level of comfort and whether or not you have attitudes about what it means socially to have a beer. So, but we are not the experts on this kind of a question. I think the expert is you, the parent and the child.
I think Dr. Ancona covered it very nicely. I would also look at the personality of the child. Some kids are, pretty, they have good self-restraint. They are better organized. They're disciplined in their own habits. They don't give in to their impulses, So that's a different child. I mean, you don't have too much danger of that child getting into repeated uses, On the other hand, you may have a child who is very impulsive and does things without good judgment. There you have to be cautious.
And I think I agree fully with Dr. Ancona's thing that it's up to the parents to really decide. But it depends on the level of acceptance in the family. The parents themselves may be drinking. And if they have a strong family history of drinking, then I wouldn't recommend it, because there may be the genetic predisposition that he's going to start. You are the wrong parent. The child should not be asking that question from the parents, because we shouldn't really permit it, sanction it, because it's like it's first of all, it's illegal for them to drink, and we are saying, hey, it's okay for you to break the law, and you are now introducing a concept of I guess permissiveness in the family. So it's against real religion. I'm sure it's against most Sri Lankan religions to drink like that. Yeah, 1 second, if you don't mind. Who is this? I called me. Hello? This is Dr. de Alwis. Can I call you back? Can you call me back in about 10 minutes? Okay, thanks. Sorry, I missed the plan of, I think. So we don't want to encourage permissiveness. It's against religion, as I was saying. Certainly for Buddhists, you're not supposed to be taking intoxicating substances. But having one beer, because one beer can lead to another one. That's what Dr. Sathananthan said before. But and as Dr. Mehta said, it depends on the child. Some may be able to get away with it, and others may not. So I think I will say, leave it to the children and say, don't ask me those kinds of questions, because I cannot give you a valid answer. But if it was my child asking at that age, I would say no. And I know that they may do it anyway.
Okay, yeah, thank you. Here's another question that came in through the panel. Is there enough education being given to high schoolers who, due to peer pressure, may start using drugs and then become addicted? A large number of those users seem to be privileged young people. And in these situations, what should parents do?
I think in New Jersey, there's a program called the DARE, which the police officers go to schools and talk about substance abuse and alcohol. But I'm not aware of the details of the program, but at least they expose them. the children now in the high school, I have my grandson in high school, they do talk about substance abuse and alcohol in their didactic classes. It's also parents' responsibility to educate these people in substance abuse and alcohol, but allow the person to evolve at like sex education. You don't have to sit down with the child and tell this is how sex happens. They learn, and they learn from school, the peers. So they also have their independent learning process. But as I always emphasize, the parent has to observe are there changes in the child's behavior, and that's where you intervene. So don't abrogate your parental responsibility. So
Yeah,
that some other school or some other.
Thank you, Dr. Sathananthan. As a parent of grown-up children, I have to say, I always thought when little kids were little, it was a big deal. But I realized as I got little kids, little problems, big kids, big problems. And as children, as parents, we have to be present when they are in that adolescent age. I think that's very, very important as parents. And I know that has been a concern, a question that's been coming up through the Sri Lankan community. Dr. Ancona, because you serve that Staten Island area, are you aware of any resources that they provide in the high schools in that area?
So when I was working for the Community Health Action of Staten Island, and also at Staten Island Hospital, we had programs where counselors, mental health counselors and addiction counselors would do programs in schools. It's a constant activity, education-wise, and sometimes they are done with police officers and community-based leaders. It's very helpful, it's very educational, and there are many evening programs that used to take place in the high schools with parents invited also. Simply educating them the same way that we've done today, but letting them know about risk-taking behaviors, educate them with respect to what programs are available for treatment, and answer questions like we're doing now. So, I mean, high school students are very prone to these kinds of risk-taking behaviors, but remember, students are very smart and educated these days. They have access to things more so. So I don't think that an authoritarian approach to this is useful as we move forward, because adolescents, college-age students are not the same as they were 30 years ago. So it would be best to wait and listen to their questions, because they will probably have the questions and the knowledge before the parents can become involved. So that's the real issue. I mean, teachers, guidance counselors, local hospitals are all aware of these problems, but I think the students themselves are prone to be more activists now if they are interested now, just as they're interested in more political and racial issues. They're taking on more now for themselves. So I think an authoritarian approach, an educational approach is very good, but students are self-activating now.
Thank you. Anyone else want to add anything before we go on to the next question?
I guess parents should help people, the children, resist the peer pressure. And you may not be able to focus just on the substance abuse alone, making sure that they hang out with the right crowd, as it were. So you've got to monitor your children to see whether there's any change in their social circles. And that might give you a warning sign about impending trouble. So the thing is to improve the child's overall self-image and improve them, help them with life skills and goal setting and those kinds of things, and not just focus only on the substance abuse. And that might help them resist the peer pressure.
Thank you. Okay, another question. What is the difference, or is there a difference between addiction versus dependence?
Yeah, in the
Again, that
earlier definition of alcohol substance abuse, the Psychiatric Association differentiated between depression and addiction, dependence and addiction. But in the last DSM-5, they put all together because it was very difficult to differentiate between the dependence and addiction. It's a very small line between the two. Also, if you just diagnose as dependence and don't address it because it's a progressive disease, it's sure to end up as an addiction. So they have now clustered everything as one disease. So people don't address them as dependence or addiction. Now they are used at abuse disorders. It's like alcohol abuse disorder, and there are criteria for how to diagnose these things. So dependence and addiction are in the past. Dr. Mehta, if you can help me out on this.
No, I think you covered it very well. I mean, there was a old differentiation between dependence and addiction, but I think you covered it so nicely that, we don't really have very hard lines demarcating one from the other. And what starts as a kind of a, occasional use, then more frequent use, and then more frequent use, at what point does it become addiction? The only definition of any addiction is that, once you reach a stage whereby you cannot stay away from the drug, because if you stay away from the drug, it produces withdrawal symptoms. And in order to control the withdrawal symptoms, you crave for the drug and you want to get that drug more. That is the very strict definition of addiction. But, American Psychiatric Association has moved away from it. We now call it all as alcohol use disorder or tobacco use disorder or amphetamine use disorder.
Thank you. Okay, so here's another question from the panel, from the session today. For one who already has a disease such as diabetes or high blood pressure and is already on medication, does the use of substances such as alcohol or marijuana make things worse?
I think the answer is absolutely yes, because we know that cardiac disease, diabetes, congestive heart failure, any physical chronic disease that's medically difficult to manage, if someone's using a substance, someone's smoking, for example, or someone's using alcohol, it definitely does make it more difficult to treat. And we don't really find these things separated, in medicine these days. Most of these things occur all together. Nicotine, is the number one substance use disorder, which we tend to sort of not talk about too much. And alcohol has a more medical overlap because we know now that it's more a medical disease in terms of it affecting the liver and the brain chronically. So with respect to nicotine and alcohol, and then other things, if people are abusing things like Xanax or opioids for pain and anxiety, that does make it more complicated. It makes it more difficult to treat.
Thank you.
There is a more recent literature besides what Dr. Ancona said. Alcohol, can cause what is called alcoholic cardiomyopathy. But also, I think those people who have existing heart diseases, one way or the other, they are more susceptible, both alcohol and tobacco. Increasingly, it has been found out that it can cause what is called atrial fibrillation. So atrial fibrillation is a irregular heartbeat, and it can lead to further problems in terms of, tendency towards strokes. Okay, so I just wanted to add on. There's a more literature coming out that both alcohol and tobacco can do that.
And of course, those are the that's the downside. And of course, there are reports that 2 glasses of red wine is good for atherosclerosis and stuff like that. So there is a bit of controversy about that. I think they say two drinks for men and 1 for females because of the difference in the way they.
Well, Dr. Alwis, it has never been. I mean, alcohol contains resveratrol, so that is a main ingredient in many of the red wines that's supposed to be cardioprotective. But to be honest with you, I looked into that, and I'm not convinced that those earlier findings are holding up.
I guess a piece of dark chocolate has the same component as well, right? Okay, thank you. Another question. Any comments on the increased use of Adderall for purposes other than social, or in the case for perceived performance and memory enhancements? Do you believe, is this true or not? I'm sorry, I'm just reading the question.
I think this is another hazard of diagnosis called adult attention deficit disorder. Attention deficit disorder used to be primarily a disease of children, but now it has become validated as an adult disease, and anybody can look up on the computer, on Google, the symptoms of ADD and go to a doctor and say, I have this problem, I can't concentrate, I'm impulsive, and I cannot perform. I think I have ADD, and then the doctor will prescribe amphetamines, Adderall type drugs, and then the person is now iatrogenic addict, meaning physician-driven addict. And I see a lot of these people coming in and asking for these kinds of medications when they never had ADD before. They did very well in school, they did very well in college, and now at work, I'm having attention deficit disorder. Of course, there is a legitimate, probably a small population of people who need that kind of stimulant to help them. So, but I would say to have attention deficit disorder, use a non-habit forming drug, at least initially, like Wellbutrin is supposed to be very good, the Ostratera. But I am not in favor of adults using Adderall type drugs.
Thank you. I think one more, it's 12, I'm looking at the time. What can family and friends say or do to an individual while that individual is in rehab and when they return from the treatment facility?
In the rehab, obviously, person, we didn't know how he or she ended up in a rehab, willingly or unwillingly. That's critical. But as I said, my talk, don't always keep that relationship between you and the addict. So there are certain visiting days during the rehab. You can visit them and talk to them. There are some family meetings there, attend them. And while they are in the rehab, you have to, the caregiver should be able to study this about the disease and see how it affects the person after the rehab. And this is also a good point for that person to attend self-help groups or think about going for therapy. That will help them to understand the person, and also together with the counselor in the rehab group to emphasize on the addict that this is not the end all of treatment. This is just the baby steps, and we'll help you with as you do the other things in your recovery.
Thank you. One last question. Is there a national helpline in the United States for general addiction questions? Or do you know of one?
I think websites were mentioned by Dr. Satha on about NIDA, I think, National Institute of Drug Abuse.
NIDA has it, and also samsada.gov has a helpline.
Yeah, both of them have it.
Okay, so we can Google them and see. Thank you. And it's 12:27, and I know we have covered all the questions that came through the chat. There was one other question, but I think we've covered it. It was about your your thoughts, and I think y'all covered it about the legalization of drugs, and I think in the and the repercussions of it, and I think y'all all covered it very well. It was a very long question, but I think you all covered that very well. I just want to take this opportunity to thank all of you. Thank you so very much. I think this session has been extremely informative and has provided a lot of information. This session, as you all know, has been recorded and will be available on the SLANI YouTube channel, and it can be shared. Once it's available, it can be shared by all, and you can send it to your friends and so on, and so they can use it and so on. With that, anything else that I missed? Shivanti, is there anything else I need to talk about?
No, I think you covered everything.
Thank you.
Thank you.
And thank you all. Oh, the other thing is that if you can all just, if there are any other topics that any of you, the community would like to hear through the collaboration with SLMANA and SLANI, where we can have this type of question and answer and presentations, please send that to us through our SLANI website or through the SLMANA website, because this is something that SLANI and SLMANA, we want to do this in collaboration together as a community service for the Sri Lankans in the US, in the New York area, as well as anywhere else. And without anything further, thank you so much to all the panelists and to the SLANI committee as well, and to SLMANA. Thank you.
Thank you.
Very good.